Hi everyone, this is Dr. Terri Messman-Moore, and in this video I want to go over how we can apply what we've learned in previous videos and lectures about assessment and diagnosis to a novel case. So I want to talk about a case that involved a woman that I had treated previously in psychotherapy. And just to let you know up front, this case that I'm going to present has been changed and modified in order to protect this individual's identity and also to protect certain details around the case so that it would prevent others. So coming back full circle, what is clinical assessment? What is the purpose? The purpose of clinical assessment is to identify what is the primary problem or what should be the primary focus of attention, either in some sort of intervention like psychotherapy or some sort of intervention such as, let's say, a medication management of symptoms, or, for example, what type of psychotherapy or type of intervention may be indicated. For example, couples therapy versus individual psychotherapy. So clinical assessment, as I mentioned before, involves numerous procedures, and we're going to use these different procedures to obtain information. And each of these procedures have strengths and weaknesses, advantages and disadvantages, and those strengths and weaknesses help us to create a picture and fill in a picture, kind of like puzzle pieces that each approach will provide some information, but that information is limited and won't necessarily give us the entire picture. So some of the types of instruments or methods that we may use to collect information for clinical assessment include psychological tests, both objective and projective tests, maybe some neuropsychological tests or neurological tests. Observations, these could be behavioral observations that we might conduct, for example, with a child in a school environment to see how their behavior may be affecting their ability to learn and sustain attention. And also interviews. And as I mentioned before, interviews can include open-ended interviews where you're following your client and having them tell you their primary concerns, or what we call structured clinical interviews, which will generally yield a diagnosis and are very thorough and reliable. So we're going to use all these types of methods, and we're going to try to solve the puzzle, figuring out what would be the best approach to helping our client. So sometimes our clients may come in with particular presenting problems, and sometimes they may not know exactly where they should start. Let me give you an example. So I want to talk a little bit about what are the ramifications of having an incomplete assessment or a wrong diagnosis, a misdiagnosis. So sometimes the presenting problem of our clients or the situation or context that they are in will not be so negatively affected by the quality or the completeness of our assessment. But in other cases, it can be. So let's talk about that a little bit. So I mentioned that I'm going to call my client Karen, and I'm going to call her the case Karen and the case of the mysterious panic attacks. So Karen contacted the clinic where I was working, and her presenting problem or her initial complaint was panic attacks. She was experiencing panic attacks, and she had a lot of physiological arousal, meaning that she was often felt her heart racing. She had maybe increased breathing. She might feel really keyed up and sweaty and just physiologically aroused a lot of the time. And one of the things that she mentioned in the intake, which is the first session that we had, was she mentioned that this was new. So one of the things that I was trying to figure out as playing detective is what is going on? Why are these panic attacks happening now? So the presenting problem was panic attacks, and her treatment goal was to eradicate the panic attacks. In other words, she was very distressed by the panic attacks. She didn't want to experience them, and she wanted psychotherapy that would help them go away. And so I was really excited about this because we have really good empirically supported or evidence-based practice for panic attacks or panic disorder. And so I thought that this could be a really straightforward case. Indeed, by self-report, she met criteria for the diagnosis of panic disorder. So she didn't come in claiming the diagnosis of panic disorder, but what she described to me by self-report and through also completing some instruments, survey instruments, she was experiencing symptoms of panic disorder as well as generalized anxiety, which is another type of disorder. So panic disorder is characterized by frequent, unexpected panic symptoms, and panic attack symptoms include things like heart racing, shortness of breath, feeling sweaty, feeling agitated, feeling very afraid, fear of dying, sometimes gastrointestinal distress. You kind of get the picture. So it's a very physiologically based condition. It's very distressing for people. The key here is that panic disorder cannot be diagnosed if you know why someone is having panic. So for example, if there's a specific phobia, let's say a fear of flying, and individuals experience panic attacks, then we wouldn't diagnose panic disorder. We would diagnose specific phobia for fear of flying. So in this case, when she told me about her symptoms, it seemed to indicate panic disorder. Similarly, when she told me about her symptoms, there was some evidence of generalized anxiety. Generalized anxiety disorder is characterized by a long-standing sense of worry and concern, and also a sense of tension in the body, difficulty sleeping, and some other types of symptoms that you would associate with stress. So that was their self-report. I followed up the self-report with a structured clinical interview for diagnosis, and indeed, she did meet the criteria for panic disorder. So now we know she's presenting with panic attacks. Her goal is to get rid of panic attacks. She's reporting symptoms that fit with panic disorder, and she does meet the criteria for panic disorder. So given all of this, what is your diagnosis? Well, panic disorder, right? So the diagnosis is panic disorder, and that's what I diagnosed my client with. So given that the diagnosis is panic disorder, what is your treatment plan? Now, my treatment plan was based on cognitive behavioral therapy and exposure therapy. So these two approaches have a strong empirical support or research support that they are efficacious for treatment of panic disorder. So we have diagnosed the disorder. The client has indicated that the goal is to eradicate panic attacks. I chose a treatment that is known in the literature for helping to reduce or eliminate panic attacks. So we can get started, right? Well, what information could be missing? So I'm going to give you a hint. There's some information missing. And the information that was missing was that her stepson was threatening her. Her stepson, who was the son of her current partner, did not like her. He was unhappy that his father had divorced his mother and that his father was now in a long-term relationship with my client. Now, just to clarify, her stepson was about 17 years old. He had a history of engaging in criminal behavior, and he had access to weapons. He also had been threatening to hurt her pet dog, and she had woken up on several occasions with him standing over her with a knife. Can you imagine how terrifying that must be? So the question is, if you know this now, what is your treatment plan? If you guessed that you would totally scrap CBT and exposure therapy, you're right. So when we think about what the implications are of an incomplete assessment and diagnosis, let's think about Karen's situation. What would have happened had I started cognitive behavioral therapy and started working with that and not known that the client was being threatened? Basically, she's experiencing domestic violence from her partner's son. Well, this is kind of what happened to an extent, but I'll tell you more about the case in a minute. So one of the major problems of an incomplete or wrong an incomplete assessment or an incorrect diagnosis is that the misdiagnosis may delay effective treatment. In other words, certain symptoms overlap between disorders, but if we do not get the diagnosis correct, we may provide the incorrect treatment. In this case, we wouldn't want to be doing panic disorder treatment. Another example is to look at symptoms of social anxiety disorder versus post-traumatic stress disorder. In both cases, individuals do experience anxiety in social situations, and oftentimes in both cases, you're seeing significant avoidance of social situations. But the difference here is that PTSD involves trauma, and therefore there is a connection between the traumatic experience and their avoidance. With social anxiety disorder, there is no identifiable trauma, and there may be other factors, including temperament or shyness, that are contributing to the anxiety disorder. So the reason it's important to diagnose correctly is because we could delay effective treatment. If we don't screen out, if someone presents with social anxiety disorder and we don't screen out PTSD, we miss the opportunity to treat PTSD, which would probably be more important than treating social anxiety disorder. Okay, here's another situation. What else could happen if we have incomplete assessment and diagnosis? Well, the misdiagnosis may harm the patient. So what do I mean by that? Well, we could give a patient treatment that makes a condition worse. So in this case, we know from the literature that if you're treating depression, you want to be very careful which medication you prescribe, depending on whether your patient has unipolar depression, or what we call major depressive disorder, or if they have bipolar depression. So typically we call unipolar depression, and typically we can treat it with a variety of medications, SSRIs and other medications that affect serotonin or dopamine. But one of the things that is known is that if you give someone with bipolar disorder who's currently in a depressive episode, if you give that person an antidepressant, you could actually flip them into a manic episode. In other words, individuals with bipolar depression shouldn't be prescribed an SSRI or an SRNI, an antidepressant. They should be prescribed a mood stabilizer. So when we don't make a correct diagnosis, we may give them the wrong medication, for example, and that can create problems. Another aspect of the harm to patients could be allowing a condition to worsen or to engage in incorrect or ineffective treatment. So in this case, this is an example with oppositional defiant disorder. So oppositional defiant disorder may involve a child not cooperating, may involve some aggression with a child between children, for example. But so we might start seeing some aggression between kids, but we may also know that the child in question has difficulty paying attention and they're having difficulty in school. So perhaps we're assuming that the child has ADHD, attention deficit hyperactivity disorder, but instead they have ODD, oppositional defiant disorder. Well, the condition of ODD is going to get worse if you treat it with the approach that you would treat ADHD, which would be a combination of behavioral modification therapy and potentially medication. So the medication and behavioral therapy for ADHD is not going to help a child who has ODD. And what it could do is make the ODD get worse because it becomes a more entrenched, more established pattern of behavior. All right. So there is one more consideration that we need to take into account in terms of an incomplete assessment or diagnosis. And in this case, this applies directly to Karen's situation. In this case, the misdiagnosis may allow the patient to be harmed by others. So had I not understood that the panic attacks were in fact related to trauma and threats that she is experiencing, I might not have been able to take effective actions and reduce the likelihood that she is harmed. So in this case, I could fail to take action to protect my client, Karen, and I could also pathologize her response. So a panic attack in the face of danger is not necessarily pathological at all. It is part of our body's response system to protect us in danger. So without knowing the context in which the panic attacks were happening, that is, not knowing that her stepson was threatening to murder her and her dog, I was at risk for pathologizing the panic attacks as panic disorder instead of correctly making the diagnosis that there is no diagnosis, she's in the midst of trauma, and we need to take action to protect her. And ultimately, that is what happened. We decided jointly that she would invite her partner to therapy and we would work together to talk with him about the behavior that her stepson was engaging in. So this is the end of this brief video looking at how we can apply assessment and diagnosis principles to a case. I hope this helped to illustrate and inform you about how we can understand assessment and diagnosis in clinical psychology and abnormal psychology. Thanks for listening.